Thomas, thank you very much for the introduction, and of course, thank you very much to the Turkish HPB chapter for the invitation, and congratulations for this very successful and very good postgraduate course. And I want to add another thank you. Thank you for the participation of so many people from Turkey at the E-AHPBA Congress in Mainz. We had more than 1,200 participants, but 43 out of Turkey. This was a great support, and I want to thank you for this support, and I also want to thank you for the friendship you gave to me. Thank you very much. Now, the topic of my talk is management of intrahepatic cholangiocarcinoma. You all know cholangiocarcinoma is about 10% of primary liver tumors. The incidence is increasing. Patients usually have very unspecific clinical symptoms. There are usually very large tumors before patients go to the physician, and very often patients only have pain if the tumor is large. Jaundice is rarely observed only in about 10% of patients. The picture here is unusual for an intrahepatic cholangiocarcinoma. Dilated bile ducts is usually not in intrahepatic cholangiocarcinomas. Tumor markers are unspecific. CR99 very often is increased, and very often we have very large and advanced tumors. So surgery for intrahepatic cholangiocarcinoma is, to my mind, in addition to perihilar cholangiocarcinoma, most challenging. This is a 10-year-old slide from Memorial Sloan Kettering, but it still shows what we have every day in cholangiocarcinoma. About half of the tumors is unresectable. At presentation in Sloan Kettering, they had 46% of exploration rate. The resectability rate is 70%. This, of course, depends on how good is your preoperative staging and how aggressive you are operating. Many tumors are not resectable because of multiple intrahepatic lesions, peritoneal carcinomatosis, or locally advanced tumors, what you see at operation. And to my mind, and this, I will come to this point later again, in future we will have more preoperative chemotherapy, more downsizing, like in colorectal metastasis, and then maybe the resectability rate will increase. Usually, if you do resection for intrahepatic cholangiocarcinoma, it is a large resection. These are data from my former working place in Essen. You see we had 80 resections, and about 50 were extended left or right resection, left and right hepatectomies 21, and only minor resection only in 12 cases, so mainly extended resection. And other cases from Berlin or from Sloan Kettering or from Italy show almost the same. Major hepatectomy in 70 to 91%. And very often you have infiltration, or at least supposed infiltration, of additional organs. These are again data from Essen. You see in 66 resection, we had in 41 resection, in half of the patients, we did 66 additional resections. For instance, resection of the hilar bifurcation, the diaphragm, vena cava or portal vein, and so on. We never know whether these structures are infiltrated before, and you see here on the right side, hilar bifurcation was infiltrated only in 2 patients, so it was not perihilar carcinoma, it was intrahepatic carcinoma, but we needed to resect the hilar bifurcation because of compression, because the tumor was close to the hilar bifurcation, and here the vessels very often are infiltrated. We never know before, so in case if there is a tumor close to a vessel and we have suspected infiltration, we do a vascular resection or resection of the diaphragm or of the hilar bifurcation. This is another example. It's the tumor I've showed before. It's an intrahepatic cholangiocarcinoma with compression of the left biliary tree. There was preoperative PDCD on the right side to relieve the jaundice, and then we had extended left hepatectomy with reconstruction of 4 bile ducts. So where are the limits of resection? I said it's almost always extended resection. One limit certainly is oncologically. If you have a tumor, like here on the left side, multifocal tumor, of course you can resect this. And you get a specimen like this, but I think it's impossible to cure a patient having such a tumor. So we would rather do an operation on these patients. In this case, we did because the patients had symptoms, but now with better chemotherapy, we would not do. And there was one paper at the E-AHPBA Congress in Mainz from Italy who could clearly show that, of course, a solitary tumor is the best, but if you have a solitary tumor with some satellites, then the prognosis is still, after 5 years, about 25%. And group 3 was multifocal tumor spread, so the disseminated intrahepatic cholangiocarcinoma, then the prognosis is poor with only 7% 5-year survival. The next one is invasion of adjacent organs. Here's one example. This is a tumor located centrally in the liver, with compression of the gallbladder, maybe even a gallbladder carcinoma and compression of the head of the pancreas. Rarely you can resect this, and here it was a central hepatectomy, a mesohepatectomy, removing segment 1, 4A, 4B, 5 and 8, and also a Whipple operation, and you see the specimen here on the right side. Rarely this is possible, but usually there is no possibility for resection. Then one limit of resectability, of course, is the infiltration of hilar or of venous structures. Here one example, infiltration of all 3 hepatic veins. In a female patient, 62 years old, she was not jaundiced, and we did an operation with resection of the vena cava and left hepatectomy, but also resection of the right hepatic vein, reconstruction of the vena cava and reinsertion of the right hepatic vein. This we could do by total vascular exclusion, but sometimes if you have to do a longer vascular occlusion, it could be possible that you should use a veno-venous bypass and cool down the liver. We do this rarely. In former times, we sometimes did an ex situ resection. I want to say this we don't do anymore. Morbidity is much too high, but we could do an ante situ resection, cool down the liver in the situs, and cut the vena cava above the venous hilum, and then rotate the liver out. We do it maybe once a year, and the same with the in situ cooling, just cooling the liver in the situs. You can cool it for 1 or 2 hours, and then you have enough time to reconstruct all the liver veins if you have an extended resection. So this is a possibility, a technical extended resection, cooling down the liver in the situs using the veno-venous bypass. We do it perhaps once a year, but we never do again ex situ resection because the morbidity is much too high. This is one case, one example where we did an in situ cooling. Here we had to reconstruct the vena cava and the left hepatic vein. You see here now the liver is clamped, it's perfused. We had to reconstruct the vena cava, and this is the specimen. So it's a rare indication, but we do it perhaps once a year. And finally, the limits of resectability functionally. If you have a small future liver remnant, we are all discussing the whole time about the ALPS procedure. Should we do ALPS procedure in intrahepatic cholangiocarcinoma? I've done so far 6, and you see my data. This is the first case I did. It's more than 8 years ago. It was a young lady with an intrahepatic cholangiocarcinoma. Bilirubin was 7. You see on the left side the dilated bile ducts. You see here probably the portal vein is infiltrated. This is why the radiologist refused to do the portal vein embolization, so I had to take the patient to the OR. You see here 400 milliliter is left lateral. She was 83 kilogram, but a jaundiced liver, so it was a critical amount of liver. And here I did an in situ split, complete ALPS. I did an hepatojejunostomy to the left bile duct here at this stage. And this is after 1 week. You see the liver is no more jaundiced. And here the specimen was an R0 resection, and the patient is now almost 100 months after operation without evidence of disease, but she had recurrence 2 years after ALPS. We did the reoperation, but now almost 100 months after ALPS procedure. To my knowledge, this is the longest survivor after ALPS so far worldwide. These are our data of ALPS. We did 17 so far in Mainz, 6 for intrahepatic cholangiocarcinoma. 1 patient died within 90 days after operation. 3 died because of tumor relapse after 10, 16, and 22 months after operation. And we have 2 survivors, 1 4 months and the other lady more than 8 years after ALPS. So ALPS is not the solution, but in rare indications, you can do it in intrahepatic cholangiocarcinoma. Now, looking at the data after resection of intrahepatic cholangiocarcinoma, of course, resection is better than exploration, and on the right side you see the R0 resection is better than the R1 resection. This is not surprising. And looking on further data, stage 1 is better than stage 2, no vascular infiltration is better than vascular infiltration, but in all groups you can find 5-year survivors. So multifocal tumor is no contraindication. Lymph node positivity is no contraindication. Vascular infiltration is no contraindication for liver resection in intrahepatic cholangiocarcinoma. What we can find in intrahepatic cholangiocarcinoma is we have in many patients, more than 50% of the patients, recurrence. Early recurrence, in our data it's after 9 months in the median we have recurrence, and in many patients, more than 50% of the patients, the recurrence is only in the liver. Disseminated tumor recurrence is maybe in 30 to 50%, but liver only is about 50% in the recurrence rate. And these data have been confirmed also in other series. This is a multi-center study from the United States. They also found that intrahepatic recurrence was in 60% after resection of intrahepatic cholangiocarcinoma. So it's similar like in colorectal metastasis. Recurrence is frequent, is early within the first year, and more than half of the patients have liver-only recurrence. I come to this point later again. And one question is always, do we have any data whether we need a large safety margin, a small safety margin? Is it similar like in colorectal metastasis where we can say that we need just a small safety margin? We only have few data regarding the influence of the safety margins. These are French data from Olivier Fage, and he could show if you have a nodal positive intrahepatic cholangiocarcinoma, then it doesn't matter whether you have an R0 or an R1 resection. But on the other side, if the tumor is nodal negative, then there is a tremendous difference if you have an R0 or an R1 resection. So it matters whether you have a small safety margin, no safety margin, or a large safety margin, but it matters only if the tumor is nodal negative. If you have lymph node metastasis, then there is no difference between R0 and R1. And going one step further, if you have nodal negative tumor, then the larger the safety margin is, the better the prognosis seems to be. Of course, it's retrospective data. Maybe you get the better safety margin if you have a solitary tumor. Maybe you get the better safety margin if the tumor is not so close to a vessel. So we cannot say for sure this is evidence, but of course what we should aim is a larger safety margin if possible to achieve, in particular in those patients where the lymph nodes are not positive. So let me summarize initially. Resection is the only potential curative therapy. The resectability rate is low, about 50%. Resection is challenging. We have hardly an indication for a palliative resection. We have a very high recurrence rate, and at least the resection margin or the width of the resection margin seems to be important, at least in nodal negative tumors. So let me continue a little bit. This is data of the literature, and it is many data about within the last 15 years. And you see there is hardly an improvement in the survival data. So things have not very much changed within the last 15 years. The results are poor, but to my mind there are some possibilities for improvement. And one possibility could be the lymphadenectomy. So far, we don't have enough data how is the extent of the lymph node dissection. We still don't know where we should remove the lymph nodes. Only in the hepatic hilum, at the left gastric curve, retropancreatic, we don't know exactly. We don't have enough data. You all know that the lymph system of the liver is very complex. It's not only the hepatic hilum, it's not only retropancreatic. We have a deep lymph system, a deep system of lymph drainage. The lymph nodes in the mediastinum are one way of drainage. The lymph nodes at the celiac trunk, the superior mesenteric lymph nodes behind the pancreas, para-aortal, these are all lymph nodes where the liver can drain. And we have a superficial system of lymph node drainage, in particular also at the left gastric curve. There's data from Italy, from Alfredo Gioelmi. He did not only do lymphadenectomy in the hepatic hilum, he also did lymphadenectomy right cardial at the left gastric artery, behind the pancreas, para-aortic, and you see in the middle that there all are at any place he found positive lymph nodes. So the system or the lymph node system of the liver is much more complex than only in the hepatic hilum, and we still do not know how far the extent of the lymph node dissection should be. What Alfredo Gioelmi could show, and they presented the data in Mainz at the Congress, is that even in small intrahepatic cholangiocarcinoma, in tumors only 3 centimeters or smaller, the amount of lymph nodes positive was very high, 30% positive lymph nodes even in small intrahepatic cholangiocarcinoma. And he clearly said we need to do lymph node dissection in all intrahepatic cholangiocarcinomas, no matter how big they are, but what is still unclear is how much lymph node we have to dissect and where we have to dissect. So the conclusion was lymphadenectomy should be performed in all intrahepatic cholangiocarcinomas, but still the extent is unclear. The next is the low resectability rate. I said about 50% are not resectable. Probably, and here I have no data, there's only 1 or 2 data in literature, that laparoscopic ultrasound and laparoscopy can lead to better staging, just to rule out patients with intrahepatic disseminated tumors or with peritoneal carcinomatosis. The next one is neoadjuvant concepts. We have many patients that are no candidates for surgery. And these are data from Mainz. We had more than 120 resections, and 8 resections were after downsizing chemotherapy, similar like in colorectal metastasis. When you see the green curve, this is the curve of the patients after downsizing chemotherapy. There are similar data from the United States that it works also in intrahepatic cholangiocarcinoma, that we can downsize initially non-resectable intrahepatic cholangiocarcinoma and can do then a resection. Maybe this will improve our data in future. Better selection, better staging. The question of PET-CT is not answered yet in intrahepatic cholangiocarcinoma. There's only little data from Corvera, but they could show that there was a change of management in about 15 to 30%. If they did a preoperative PET-CT scan, they could find tumor deposits in the chest before doing a hepatectomy, so they could exclude those patients. The data are too small to draw a conclusion, and so far from the guidelines from the EASL, they say PET scan is not accurate for early diagnosis of intrahepatic cholangiocarcinoma, and its role as a staging modality remains controversial, but this could be a measure of the future to improve our staging if we could include preoperative PET scan. The next one is need for adjuvant concepts. So far we had no adjuvant treatment in intrahepatic cholangiocarcinoma. You all know that this has changed a little bit since the data from the ASCO this year. John Primrose gave us the data of the BILCUP trial, and now, at least in Germany, post-operative treatment with capecitabine is the new standard in intrahepatic cholangiocarcinoma. So now we have adjuvant therapy in intrahepatic cholangiocarcinoma. We do it in all our patients, and we will see whether this will really improve our results. The next is many patients have intrahepatic recurrence. So far, most of the patients were treated by chemotherapy only, but we have increasing evidence that a repeated resection, similar like in colorectal metastasis, can also improve the results in intrahepatic cholangiocarcinoma. These are data from my institution. You see we had 127 resections. We had a recurrence rate of 66%, and the median time to recurrence was 11 months. And here again you see intrahepatic only is in 40%, and we had repeated operations and explorations in 16 of these patients. This is one example. Recurrence after right hepatectomy, recurrence close to the left hepatic vein, and this is the operative situs after re-resection of this tumor. These are our data. The blue line is the data of the patients having a re-resection. This is the data of all the patients, so it looks as if the resection group is much better than the resection group. This is a biological selection, but of course it shows that if possible you should do a repeated resection in intrahepatic cholangiocarcinoma. And if you say re-resection is worthwhile, then of course you should also do a structured follow-up. Recurrence is early, and so most of the tumor recurrence are within the first 2 years. So we do a structured follow-up every 3 months within the first 2 years to detect intrahepatic recurrence and just not to miss the opportunity to do a repeated hepatectomy. And finally, similar like in colorectal metastasis, what is the role of molecular biological treatment of targeted therapy? So far in intrahepatic cholangiocarcinoma, we have no evidence. It is not ready for clinical application, but I'm sure here will be in future some development, and this will be the future also in intrahepatic cholangiocarcinoma. I thank you for your attention.